Hello, my name's Lynn Jones and welcome to the Motivational Midwife. Today we're going to follow on from the liver video and look at obstetric cholestasis. Okay, so let's look at intrahepatic cholestasis of pregnancy, or obstetric cholestasis as is more commonly known. And this is a disorder that's completely unique to pregnancy, and it's where there is an impairment of the maternal bile flow, and we'll revisit the liver in a little bit of detail just to remind you of that. It affects just under 1% of all pregnancies in the UK, and this figure seems to be largely unchanged, although I would say anecdotally, I certainly see more women presenting with these symptoms than possibly I did earlier in my career. But the most recent RCOG guidance, which came out this year, and I will put a link to that in the box below, the still states 0.7% as the incidence rate. So women of Indian or Pakistani Asian ethnicity are more likely, they have an increased risk of developing OC. And Hep C positive women, so there's already some liver involvement there, have an increased chance, quite a high increased chance of developing obstetric cholestasis. It is a condition that is multifactorial, but it is characterized by itching, okay, and that's itching in the absence of an already pre-established skin condition. So say something like eczema, which is very itchy anyway. These women usually don't have any pre-existing skin disorders, and it's characterized by this severe itching. There's also abnormal bile acid concentrations, and we'll talk about those in a little bit more depth later. It usually presents in that third trimester or late second trimester, and it's important that we really exclude other diagnoses such as PET as well. And importantly, usually once the baby is born, then the itching resolves and the bile acid results will return to normal, although this could take a little while. So let's just have a quick reminder of what the liver does. Okay, it's an organ of digestion. It's made up of loads of lobules, and those lobules are full of liver cells that go right round a central vein and radiate outwards. And within the liver's capillary system, so that's the one that actually helps carry the blood, so oxygen-rich blood from the artery and nutrient-rich blood from the vein. That's your hepatic and portal veins, hepatic artery, portal vein. They're sort of called sinusoids. It's one of its main functions is in metabolism, so metabolizing carbohydrates, fats, and proteins. It also is an organ of detoxification, so drugs, alcohol, any sort of toxins. It's the liver's job to try and detoxify that, make it less toxic to the body. It converts ammonia into urea for excretion, and it synthesizes our plasma proteins, non-essential amino acids, and essential nutrients. And for the purposes of OC, it also secretes bile. So what does bile do? Well, bile emulsifies fat. So that just means it helps combine it to make a smooth solution. Okay. It promotes the absorption of fatty acids. cholesterol and other lipids, and it gives feces its colour. So, clearly gone large text here. I don't know what I was thinking about here. So the clinical features, as I say, these women present with severe itching affecting the limbs, the trunk, but classically the palms and the soles of the feet. And this is severe itching. They are scratching themselves senseless to the point that they will break the skin often. As I say, it presents late second or more commonly third trimester, and it's often to have itching everywhere, but not the face. And you'll have excoriations, so broken areas, but without a rash. Symptoms might precede any actual blood abnormalities, any biochemical abnormalities by days or weeks. So they may present with symptoms but have normal blood work. And those women we're going to just watch very closely. There won't be necessarily a skin rash. Their liver function tests will be abnormal, and if you're testing their urine, it will often look very dark. Stools can often be very pale, and often there is some anorexia as well. There's also malabsorption of fat with steatorrhea. Well, that just means you can see fat in the stool. There's often a strong family history of this, so it is important to ask if any other family members have suffered with OC. And there is some suggestion that it may be an autosomal dominant inheritance pattern to the disorder. And interestingly, oral estrogens may precipitate similar conditions. So when we're talking about contraception to women, we need to be mindful that estrogen-based contraceptions may not be the most appropriate ones for these women to be offered, and if there's an alternative. So how are we going to diagnose it? So increased total bile acid concentration, and a bile acid result of over 14 is deemed to be suggestive of OC. But it's important actually that this sample is a fasting sample, because having eaten and had a meal, your bile acids will go up naturally. And so you may find that this is giving a false positive reading to some women, and if you actually did a fasting sample, they would be within the normal ranges. Raised transaminases, raised gamma-glutamyl transferase, and a mild raise in bilirubin is less common. So these are all liver, part of your liver function tests. So if a woman presents with itching, no rash other than the excoriations from the itching, then we take her bile acids. Okay, so that has a greater than 90% sensitivity, but it is only 50% specific. And we can repeat that at weekly intervals depending on what those results are. Liver function tests should be undertaken weekly, because these will give you an indication of how severe the disorder is or how it's progressing. Coagulation profiles, and also doing hepatitis screening if they haven't had it already, but it's worth doing it again. Sometimes an ultrasound of the gallbladder or liver, and liver autoantibody screening as well is sometimes undertaken. So when we're looking at bile acids, so the most recent Green Top guidelines, RCOG Green Top guidelines, have altered the historic values very slightly. So now bile acids between 19 and 39 are considered to be a mild obstetric cholestasis, and between 40 and 99 moderate, and those that are above 100 are definitely severe. And our transaminases up to 300 in more severe cases. alkaline phosphate is 5 to 10 times the normal limit, the normal results you would be expecting. And as I say, some women will have slightly elevated bilirubin levels, but it's not normally, it's not usually greater than 85.5. So the prothrombin time, so clotting time, might be longer in rare cases where they've actually got some vitamin K depletion because the liver is not functioning properly. And when you carry out a hepatitis virology, then it will come back. If there's hep C infection, that will come back as positive. So it's important that we differentiate against other possible things. So acute hepatitis, these women will usually appear unwell, and they'll present with that feeling of unwell. They'll have right upper quadrant pain. They'll have predominant constitutional symptoms, nausea, sometimes vomiting as well. HELP syndrome, the typical signs of our PET, so high blood pressure, thrombocytopenia, proteinuria, but around 20% won't have high blood pressure, but thrombocytopenia will distinguish it from obstetric cholestasis. And then our acute fatty liver of pregnancy, these patients usually will appear quite unwell, frequently with malaise, nausea, typical signs of preeclampsia, coagulopathy and renal impairment. And more than 70% will have hypertension present as well. And then our pups it typically present with really itchy papules, and it might be quite difficult to differentiate clinically because it may present in a rash-like appearance with women with obstetric cholestasis as well. Okay, so risks for mother. Vitamin K deficiency. Okay, so there's that malabsorption of our fat-soluble vitamins. This is very, very rare. I don't think I've ever seen it or even heard of it, to be fair. If there is an uncomplicated obstetric cholestasis, then there is no increased risks of postpartum hemorrhage. But actually, if there's other things going on as well, then these women are at some increased risk of PPH. So that should be in the back of your mind when you're considering your management for labour. So risks of stillbirth, and this is one that's always been bandied about quite a lot with obstetric cholestasis, and I think it's quite useful that the new guidance does break that down into mild, moderate and severe, because when we start looking, as we go through this and we start looking at the actual risk factors, then it does mean that you can give women more evidence-based information to make an informed choice. And certainly I have had a client recently who was offered induction at 37 weeks, and I think her bile acids initially were about 13, and they were very well read, and they read up about it and said, well, what is our individual risks? And sadly, the midwife didn't know. And so they went off and investigated and found that actually the risks were only really very high with bile acids above 100. So they were quite a way off that. So they chose to decline induction but carry on with monitoring. And actually, she eventually took her pregnancy to 43 weeks. So it just shows you that actually we could have intervened unnecessarily for that lady and potentially caused more harm than good. So it is important that we do have this evidence-based information to allow women to make an informed choice. So with mild obstetric cholestasis with no other risk factors, The risks of stillbirth are exactly the same as the background population. So the advice is to consider delivery around term or continue close monitoring. And if there is a moderate ICP but no other risk factors, the risk of stillbirth is the same as the background population until they get to about 38, 39 weeks, and then it seems to increase at around that gestation. So offering delivery around that term or induction around that time would be certainly an option. But those whose bile acids are greater than 100, so severe ICP, the evidence suggests that they definitely have a higher than background risk of stillbirth, and therefore delivery should be considered around the 35, 36 week mark. And there we have to weigh up the pros and cons of delivering a baby preterm to seeing it out. And obviously, if you have multiple pregnancies or there's other comorbidities going along with the ICP, then you are going to increase those risks of stillbirth. And this is something we need to discuss with women. The RCOG, actually, and I will put a link to this on as well, do have a very useful patient information leaflet on this. So it would suggest that the women who have obstetric cholestasis seem to have an increased risk of intrapartum fetal distress, spontaneous preterm births. So often these women will go into labour spontaneously anyway, preterm. And then obviously iatrogenic preterm birth, this is where we are really hastening the birth because of the risks to the fetus. And meconium is much more common in our preterm babies with raised bile acids above 40. And then there's the risk of intracranial hemorrhage. So that's definitely something to really look out for, particularly if you've ended up with an instrumental delivery or something where there may be some trauma to the head. So these women should be ideally consultant-led care and advised to deliver in an obstetric unit where they can be closely monitored. They do need to be counselled in respect of both the risks to themselves and the risks to the baby. And obviously there are far more risks to the baby than there are to the mother. If she presents with itching and her liver function tests are essentially normal on the first visit, then it's suggested that 2-weekly monitoring of those LFTs is appropriate. But with weekly antenatal clinics, liver function tests and bile acids if they are initially abnormal. If the bile acids are above 40, then really a consultant appointment should be arranged so that the women can determine a management plan in conjunction with their consultant. From a midwifery point of view, we should be doing weekly urine and blood pressures because we are trying to exclude that differential diagnosis as well of PET or an abnormal presentation of PET that may be bubbling away there. There are no treatments that are going to reduce perinatal outcomes at all, but there are medications that can be given to reduce the itching and therefore make the women slightly more comfortable. In labour, certainly if the bile acids are greater than 100, so you've got that increased risk of stillbirth, and all the other complications, then continuous CTG would be offered. There is, interestingly, insufficient evidence around continuous electronic fetal monitoring for bile acids below 100, but I would say close monitoring, whichever form of monitoring you choose to you decide upon with the woman, remember we have got that sort of increased intrapartum fetal distress suggestion as well. So it doesn't, they do need to be quite closely monitored. However, the women have chosen to be monitored. And obviously, if there are comorbidities there, then that is going to affect the management plan. So postnatal, it does usually resolve post-delivery, but we need to repeat those LFTs at least by 1 month postnatal, just to confirm that everything is going back to normal. And the women should be counselled that there is, a significant risk of recurrence in future pregnancies. And as I said earlier, about avoiding estrogen-containing oral contraceptives if possible. And there you have it, obstetric cholestasis. I hope that's given you a little bit more understanding of the disorder and how we currently treat it. Obviously, as always, look for the most current guidelines. And if you haven't subscribed to the channel already, please do so. And I look forward to seeing you next time.